Hello everyone, today we'll be talking about headaches. Headache is an almost universal experience and one of the most common symptoms in medical practice. It varies from an infrequent and trivial nuisance to a pointer to serious disease. Basically, what they mean is that it can be due to tension or just some nuisance, and sometimes it can be a sign of a serious disease. So, headaches shouldn't be ignored. Headache symptoms are unpleasant, disabling, common worldwide, and have a substantial economic impact because of the time lost from work. So, what is the mechanism of headache? Pain receptors are located at the base of the brain in arteries and veins and throughout meninges, extracranial vessels, scalp, neck and facial muscles, paranasal sinuses, eyes and teeth. Curiously, brain substance is almost devoid of pain receptors. Head pain is mediated by the fifth and ninth cranial nerves and upper cervical sensory roots. So, in this video, we're going to focus more on primary headache disorders. But if you're interested, you can let me know. I can upload a video on secondary headache disorders as well. So, the first primary headache disorder we're going to talk about is migraine. Migraine is the commonest cause of episodic headaches, which is 15 to 20% of women and 5 to 10% of men. In 90% onset is before the age of 40. Episodes of headache are associated with sensory sensitivity such as to light, sound, or movement, and sometimes with nausea and vomiting. There is a spectrum of severity between individuals and from one attack to another. So you can't say last time my migraine felt this way, this time it's different, because it doesn't necessarily have to be the same. Migraine is usually high impact with inability to function normally during episodes. Headache frequency in migraine varies from an occasional inconvenience to frequent headaches severely impacting quality of life and may transform into chronic daily headache. So what's the mechanism of migraines? Genetic factors play a part in causing the neuronal hyperexcitability that is probably the biological basis of migraine. Migraine is polygenic, but a rare form of familial migraine is associated with mutations in the alpha-1 subunit of the PQ-type voltage-gated calcium channel or neuronal sodium channel SCN1A, and a dominant loss of function mutation in a potassium channel gene TRESK has been recently identified in some patients with migraine with aura. The pathophysiology of migraine is now thought to have a primarily neurogenic rather than vascular basis. Spreading cortical depression, a wave of neuronal depolarization followed by depressed activity, spreading slowly anteriorly across the cerebral cortex from the occipital region, is thought to be the basis of the migraine aura. Activation of trigeminal pain neurons is the basis of the headache. The innervation of the large intracranial vessels and dura by the first division of the trigeminal nerve is known as the trigeminal vascular system. Release of calcitonin-generated peptide CGRP, substance P, and other vasoactive peptides include 5-HT by activated trigeminal vascular neurons, causes painful meningeal inflammation and vasodilation. Peripheral and central sensitization of trigeminal neurons and brainstem pain pathways makes otherwise innocuous sensory stimuli, such as cerebrospinal fluid pulsation and head movement, painful and light and sound perceived as uncomfortable. So, what is the diagnostic criteria of migraines? So, headache lasting 4 hours to 3 days, that is untreated headache, and at least 2 of unilateral pain. It may become holocranial later in attack, but initially it should be unilateral, throbbing type of pain, moderate to severe in intensity, motion sensitivity. Headache made worse with head movement or physical activity. So at least 2 of this and at least 1 of nausea or vomiting, photophobia or phonophobia, and normal examination and no other cause of headache. So this is basically you examine the patient and then you find no other cause. Basically what you're referring to is secondary causes of headache. So what is the management of migraine? So general measures basically include explanation and avoidance of trigger factors and lifestyle modification where possible. So what is the acute treatment of attack? So you can give analgesics such as high-dose dispersible aspirin, 900 mg, paracetamol 1 gram, or NSAID, agent naproxen 250 to 500 mg. These are often effective, and as we have said that some may be associated with nausea and vomiting, so you may give an antiemetic such as metoclopramide if necessary. Acute treatment should be taken as soon as possible after onset of headache. However, patients should be aware that repeated use of analgesics leads to further headaches. Then another mode of treatment is the triptans, that is 5-HT1B or 1D agonists. These are specific for migraine and may be effective where simple analgesics are insufficient. Sumatriptan was the first marketed. Almotriptan, elatriptan, fervotriptan, naratriptan, rizatriptan, and zolmitriptan are now available with various routes of administration. Then what medications can we be taking to suppress migraines? So where migraine episodes are frequent, e.g. you're having more than 1 or 2 episodes per month, and they're impacting on the quality of life, migraine suppression medications should be offered. The key principles are that a period of 3 to 6 months treatment is usually sufficient to reduce headache frequency and severity by approximately 50%, with the effect of resetting migraine frequency beyond the treatment period. However, these medications will not be effective where ongoing analgesic overuse is an issue. Treatment options include anticonvulsants, valproate 800 mg used off license, or topiramate 100 to 200 mg daily are generally the most effective options. Then we can also give beta blockers, e.g. propranolol slow release 80 to 160 mg daily, tricyclics, e.g. amitriptyline 10 mg, while you increase the dose weekly in 10 mg. Well, you can step up to 50 to 60 mg. Botulinum toxin was recently recommended as a treatment for chronic migraine. The technique involves 31 injections over the scalp and neck repeated every 3 months. Pizodiphen is rarely used. Flunarizine, a calcium antagonist, and methotrexate are used in refractory patients. So that was all about migraines. Now we move on to tension type headaches. The exact pathogenesis of this headache type remains unclear. There is overlap with migraine, and many headaches traditionally subsumed under this category probably in fact represent mild migraine. Since there are no diagnostic tests to separate tension type headache from mild migraine, it is difficult to know if the conditions are biologically distinct. In contrast to migraine, pain is usually mild to moderate in severity, bilateral and relatively featureless, with tight band sensations, pressure behind the eyes, and bursting sensations being described. If you remember what we talked about under migraines, we said that the pain is usually moderate to severe and it usually starts as unilateral. Yeah? Okay. Then we're going to talk about trigeminal autonomic cephalgias. The trigeminal autonomic cephalgias are a group of primary headache disorders that are characterized by unilateral trigeminal distribution pain, usually in the ophthalmic division of the nerve, and prominent ipsilateral autonomic features. So these types of headaches are associated with autonomic manifestations. Then we talk about cluster headaches. Cluster headache is distinct from migraine and much rarer, which is 1 per 1,000. If you remember, we talked about migraines. The thing was 10 to 20% in women and 5 to 10% in men. Yeah, it's rare. It is 1 per 1,000. So it affects adults, mostly males aged between 20 and 40. Patients describe recurrent bouts of excruciating unilateral retroorbital pain with parasympathetic autonomic activation in the same eye, causing redness or tearing of the eye, nasal congestion, or even a transient Horner's syndrome. The pain is reputed to be the worst known to man, and patients often contemplate and sometimes commit suicide. Such is the severity of the pain. Unlike migraine attacks, patients prefer to move about or rock rather than remain still. Attacks are shorter than migraine, usually lasting 30 to 90 minutes, and may occur several times per day, especially during sleep. Clusters last 1 to 2 months with attacks mostly at nights before stopping completely and typically recurring a year or more later, often at the same time of the year. Although the cause is not known, hypothalamic activation is seen on functional imaging studies during an attack. So what is the management of cluster headaches? Analgesics are unhelpful. Subcutaneous sumatriptan is the drug of choice for acute treatment as no other drug works quickly enough. High flow oxygen is also used. Most prophylactic migraine drugs are unhelpful. Verapamil, lithium, and or a short course of steroids help terminate a bout of cluster headaches. Now we'll talk about chronic daily headaches. This is defined as headache on greater than or equal to 15 days per month for at least 3 months. So chronic daily headache is not just you have had headaches for 3 days and you start calling it chronic. No, how you define it is headache that is greater than or equal to 15 days in a month for at least 3 months. Up to 4% of the population are affected by daily or near daily headache. Although there are many possible causes including secondary headache disorders, in practice, primary headache disorders, particularly migraine, are responsible for the majority. Where migraine is the cause, the term chronic migraine is now preferred instead of chronic daily headache. Overuse of analgesic medication or triptans, termed medication overuse headache, is often a major factor leading to and maintaining chronicity, particularly in those with migraneous biology. Use of greater than or equal to 10 doses per month of any analgesic or triptan, particularly codeine or opiate-containing drugs such as cocodamol or numerous of OTCs analgesics, may eventually lead to transformation of episodic headache into chronic daily headache. So basically what we're saying is that overuse of analgesics is a risk factor for a person developing chronic daily headaches. Explanation that medication overuse is part of the problem is essential to help patients withdraw from or substantially reduce analgesic intake. This is a difficult process for many patients, especially as there may be a period of transient rebound worsening of headaches after withdrawal. Concurrent introduction of migraine suppression medications may help withdrawal but will not be effective if patients cannot withdraw from frequent analgesic use. Occasionally, hospital admission for analgesic withdrawal with parenteral administration of dihydroergotamine is required. So that's all about headaches. If you like the video, please like, subscribe and comment. And if you'd like me to talk more on any specific type of headache that I've already mentioned, or if you'd like me to talk on secondary headache disorders, please do comment. Thank you.